Good morning. Welcome, everyone. We are here today to talk about the importance of protocols in terms of achieving efficacious scalp cooling. My name is Lindsay Peterson. I am a medical oncologist at the Washington University School of Medicine in St. Louis, Missouri. We've been offering scalp cooling to our patients for a few years now. We think it's a very important tool to be able to offer to our patients who are receiving chemotherapy in terms of trying to reduce the chemotherapy-induced alopecia. So we've got a great panel here this morning that we're going to have a nice little chat and try to talk about the importance of protocols in delivering scalp cooling. So we'll start with introductions. Dr. Isakoff, would you like to go first?
Thanks. My name is Steve Isakoff. I'm a breast medical oncologist at Mass General Cancer Center in Boston, and my primary interest is in clinical research, primarily in triple-negative breast cancer and focusing on novel therapies. But we've been interested in scalp cooling with the Paxman system for about 4 years now, and scalp cooling in general maybe for about 8 years, and we've treated several hundred patients over the last few years. And the interest really stemmed from recognizing a major side effect of treating patients with scalp cooling and recognizing this was a huge need for patients. And so I founded our program at our institution about four and a half years ago. Thanks.
Wonderful. And Dr. van der Hurk?
Hi, I'm Corina van den Hurk. I'm a researcher at the Netherlands Comprehensive Cancer Organization. And I'm on the field of scalp cooling since 2 decades already. I introduced scalp cooling in the Netherlands, and we did quite some research on the topic. And besides, I'm also the co-chair of the oncodermatology study group of MOSC.
Wonderful. And Dr. Ross?
Hi, my name is Michael Ross. I'm a nurse practitioner on the breast medicine service at Memorial Sloan Kettering Cancer Center. And I just have to say, Dr. Peterson, I used to work at WashU in St. Louis. I'm a former St. WashU alum in terms of work. So shout out to WashU in St. Louis. But anyway, my interest in scalp cooling really started as I was doing my graduate work. And for the nursing research question and course, we were asked to look into a topic. And at that time, it was 2015, and it was very serendipitous that at that time in 2015, we were really starting to get some data from protocols. So I feel this session is just so ripe in terms of once the data from protocols became available, then the confidence to move forward with scalp cooling in the clinical setting was there. And so as a result of that research, I was able to be part of the group that actually brought and spearheaded bringing scalp cooling to Memorial Sloan Kettering Cancer Center.
Wonderful. And Elisa?
Hi, nice to see everybody. My name's Lisa Mills. I'm the interim national quality lead for cancer services at Nuffield Health. So I'm a registered nurse. I've been using scalp cooling pretty much the whole part of my career, Paxman and other systems. And from my perspective, I suppose one of the biggest things from being a quality lead is supporting patients throughout their journey. And often some of the side effects that can be underestimated in what's important to patients. So for me, I'm a real advocate for being able to support patients in every way possible, not just in the sort of the more medical aspects of cancer care. So it's really exciting to be here. So thank you.
Wonderful. So we've got quite a diverse panel this morning, and that's wonderful. Varying levels of involvement with scalp cooling, lots of interest in terms of research. And so, one of the things I think that we want to highlight is that scalp cooling has come a long way from when patients had to initially bring their own equipment and worry about transferring one cap to another as one would lose its cooling. And the ability to deliver scalp cooling now in a much more effective manner has really been wonderful for patients and has allowed us to use it on a much larger scale. And although we have come a long way, and although it is a much easier process than it was in the beginning, it's still important to have protocols in place to make sure that we are giving patients the best opportunity to really come out with an outcome that they're pleased with. And so, one of the things is that everyone has a role in scalp cooling. The patient has a role, the nursing staff has a role, and the physician has a role. And so one of the first things I want to talk about is just hearing from everyone how that works at your own institution and who takes on what roles to make sure that the patients have the best experience possible. Dr. Isakoff, would you like to start?
So I completely agree that protocols are very important. I think like anything else, repetition and breeds consistency and really can help improve the outcome. So when we started our program, we actually started having a scalp cooling program meetings, and we would meet actually monthly involving all the stakeholders. We had representation from the infusion room nursing staff, from the scheduling staff. We had a program coordinator / research assistant who helped organize things. We had our practice nurses in the clinic. And we talked about what workflows would work best and sort of what roles. And so as an example, we've established a system and a workflow where, as the provider, either the MD or the NP, whoever's meeting the patient, brings up the idea of scalp cooling and does a little introduction, but then we've established a process where our practice nurses can then be called in real time on the fly without a scheduled appointment to come in and do the fitting and go over some of the initial information. And when we set up our structure, we thought it was very important in terms of protocols not to have the patient have to come back. We just decided for our institution that was adding an extra burden on the patient, and if we could get that done at the first visit, it would be one less delay and one less barrier to getting things started. So our practice nurses took on the bulk of that role. We sort of recognized that our infusion nurses were going to be very busy teaching about chemotherapy on their day of treatment. So we wanted to try and minimize the impact on the infusion room staff, although over time they've sort of taken the role as they've gotten more used to it and have done this over and over now for more than 4 years, where they can provide some same-day teaching. But really a lot of our sort of established workflows happen well before the patient comes in. We very strongly encourage patients to review the materials, to practice putting on the cap at least several times, 3 times before they come in, watch all the videos. And I think as much preparatory work and sort of consistency that way can really help improve the experience for the patient, number one, because it can reduce the anxiety on the day of treatment, but also improve the outcomes. So that's sort of been our approach.
Wonderful. Yeah, I like what you said about all the prep work. I think it really is important. And I think that the longer institutions have experience with this, the easier it is to sort of put in that effort up front. We also try to minimize the patient returning. And so fitting that cap, I think, on that first visit, whether the patient's committed to scalp cooling or not, if you can get them that fit so that all they need to do going forward is, fax in a piece of paper and they don't have to come back, that's often very helpful for the patients. Dr. Vanderhoek?
Well, I'm not working in a hospital. I'm working at a research center, but I know that in the Dutch hospitals, mostly the nurse is providing information on scalp cooling, and then they, of course, also do the cap fitting already. Then during the first chemotherapy, the patient comes to the hospital, and then also there's a short information and also, applying the cap and it's mostly done by the nurse, so it's really nurse-led. And while we're talking here now already, I'm also thinking, okay, so we are talking about a little bit evidence-based protocols, but mostly still practice-based protocols. And is it nurse-led mostly? So I'm really wondering what you guys experience in your hospitals on that topics.
So we have a workflow that's very similar to that as outlined by Dr. Isakoff. During the initial consultation and on our service breast medicine, the same as GYN or even some of our folks in prostate, we've had a reasonable uptake in the prostate group as well, is there are many things that are addressed by the medical oncologist. And so on a top level, the medical oncologist will talk about, this is available. Very top level, be able to give some data in terms of what the expectations are. We tend to use a lot of anthracyclines. And so the medical oncologist will set the expectation that the outcomes certainly are better with cooling than not cooling, but around 20% in terms of successful hair preservation with an anthracycline, as opposed to a weekly Taxol with Herceptin, which has a much better outcome. So we really try to set that expectation in terms of efficacy and also then expectations in terms of cost and tolerability. Once those expectations are set, that part of the workflow then is if the patient indicates any interest whatsoever, hey, if you think you might do this at all, as both of you, all of you have mentioned, it can be very difficult for the patient to get back in. Then they transition that workflow off to the clinic nurse, who is really quite expert in fitting the caps, both the inner and the outer. And then, once that fit has been established, once again, as mentioned previously, education becomes key. Patient education, reviewing the videos. We really talk to our patients quite a bit about being self-empowered. This is your opportunity to really self-manage this. And we also feel that this allows the patient to take some ownership in terms of the outcome, in terms of how that cap gets on that head and gets that best fit. And then once again, trying to minimize the time in the infusion suite. So we have found that very medical oncologist kind of sets expectations in terms of efficacy, in terms of safety, in terms of cost and tolerability. Then the office practice nurse really handing off the nuts and bolts, getting it fitted, and then really providing all the education for that person to be self-directed and be able to manage the majority of the the capping process from there forward.
Definitely sounds like a lot of similar practices out there that are working for people. Elisa?
Yeah, I mean, I think there's very, very much some similarities, and a lot of what Michael's just said is very similar sort of in my practice. I think we are very heavily nurse-led. So where the consultants will obviously discuss side effects, they don't necessarily go into the huge amounts about the management often. I think that's probably because the service has become so nurse-led now that they feel that is the best way to do it. And actually they can spend time on other areas, which is probably more important for that sort of medical clinician and patient relationship. So we very much have either nurses or sort of nurse practitioner assistants that will support the patient in that journey from the sort of the discussion of how effective it might be, the best ways they can do it. But especially I agree with what Michael said around that self-empowerment. It's something that the patients can help themselves with, which is so important because we take everything away from them in their journey, in essence, that it's something that they can actually physically try and do for themselves. So very much done as a one-stop shop as part of a chemotherapy pre-assessment. So the sort of sizing and all the documentation for the staff. So when they come on that day of treatment, as everybody else has said, it's all ready for them to go. They've hopefully been prepped, the head's ready to go, and sort of they're ready for the day ahead, really, which again, for some of the things I know we're going to discuss today in terms of capacity issues and things that happen in these environments, it's so important from that perspective as well. So that we can get those patients to have the treatment without any constraints of time. So I think similarities, but very much we are very heavily nurse-led with a little bit of sort of consultant input. But yeah, some consultants will discuss it more than others, I would suggest, but a lot of similarities.
And I just want to emphasize, I really like what Michael said there too about patient empowerment, because we really take that approach as well. We don't require a consent form in the classic sense, but we do have an acknowledgement form, which we go through with the patient and have them sign, where we say, you are responsible for this. You have to contact Paxman or whatever company you're using. You need to bring it at each session. You need to practice. And really try and empower them to feel ownership of this process. In part, it's a practical thing. We just, we don't want to dedicate staff resources to things that the patient can certainly do themselves. But in large part, it's really a patient empowerment thing to make them feel like they're really having a major role in this. And as others have said, give them a sense of control over this part of their care, and I think that works well for most patients. And it's not just the day of treatment. I mean, there's care that has to be done in between, so it is really important to make sure they know that between 3-week treatments or weekly treatments, it's really their responsibility to follow the instructions and to try and get the best outcome for their hair.
And one other point I would just add, if there is a center where the volume is quite low, as we were kind of coming on board and ramping up in terms of the number of people that were actually utilizing scalp cooling, we did find it quite helpful to have quote unquote super users in terms of the nursing staff So until the uptake was broad enough that all nurses could feel competent to play their role in supporting the patient, we really did, at our main site plus all of our regional sites, had a couple of super users that really could kind of QC the process a little bit, as well as act as a resource for other nurses that were coming on board and expanding their practice. Once again, patient-led initiative, patient-empowered, but really, if the volume's not quite there, to have a few key stakeholders and super users, experts, that's been a real help for us.